So my name is Michelle Wong. I am from the Department of Healthcare Services, and I work in our Substance Use Disorder Compliance Division. We have the pleasure of holding the External Quality Review Organization contract for the Drug Medi-Cal Organized Delivery System waiver. And so we've been working very closely with behavioral health concepts, with developing the tools and the processes related to those external quality reviews. I'm just curious, how many of you actually sat in and listened to the webinar yesterday? So quite a few of you, so I won't repeat everything I said yesterday, but we're really pleased to be able to work with BHC on this contract. We're lucky that they also hold the mental health contract for the external quality reviews. I know that, I mentioned yesterday that there are differences that we recognize, but then of course similarities, because there are standard requirements related to the external quality review process. And so with that in mind, a lot of the work that went forward in developing the tools and the toolkit that Rama likes to call it, and I think that's a great idea, because it is a toolkit for the counties to help you prepare for these reviews. We know that they can be a little intimidating for somebody to come in and look at what you're doing, but ultimately our goal at DHCS and BHC is we want to really look at to see, what's going on at the county, focusing on quality and access and timeliness and outcomes. Because ultimately, we really want to make sure that the system that is being provided is the best for the beneficiaries within your organized delivery system. And that's really important to us. So I will say that you have no better advocate than Dr. Rama Khalsa here. She's worked really hard to try to reach out to counties and really get the input of people working in the field and directly with the providers to ensure that hopefully these tools that we're utilizing to look at all of these great things are really effective, because there's no point in going forward and doing a review that's going to give us no information at all, really. That's not going to be beneficial to really changing things and ensuring that we're moving forward with good changes and not just making changes for the sake of making changes. So with that, I really do want to thank her for all the work that she's done and all the work that her team has done. We have Dr. Tom Traben here as well from BHC, and you know that he has plenty of county experience, so we're really lucky to have him on the BHC team as well. So with that, I won't take up any more time. I do want to thank them for setting this all up. I think this is great to be able to walk through the toolkit and get your input and feedback as well. And so with that, I'm going to turn it over to her. So thank you, everybody. I hope you enjoyed today.
Thank you, Michelle. So I'm going to start with a little logistics. We are filming this, and we are going to be putting it on YouTube. And we want to make sure we capture all your questions as we go through the day. And so we will have to ask if it's possible when we do our specific breaks related to questions, if you could come up here and do that. And if you don't want to be on YouTube, you could ask maybe someone at your table to ask your question. But we hope that'll be okay. And the restrooms are over on the side here. And what we'll be doing is we'll be going for about 45 minutes and then taking a break with questions. And then we'll restart with the actual toolkit. You should have been able to get 2 documents yesterday. One is the PowerPoint, and the second is the actual toolkit, which is about 160 pages. So we didn't want to kill a million trees today, and so and we are asking folks to sign in so we can make absolutely sure you have all the materials we discussed. So we really appreciate you being able to do that. And I do want to acknowledge DHCS has been super supportive of us focusing on training and preparation and positive engagement around our performance measures. Michelle and Ilana and Wahida here have been just awesome. And it's kind of like the ideal relationship when you can see a department so committed to the waiver and everybody trying to help make it successful for our clients and for the community. And that's, very inspiring for all of us. And so I'd like just briefly for the BHC staff to stand just to make sure they're all introduced. So you'll see some of them on reviews. There's Tom Trabin and Kimberly, who is our administrative person who supports DMC, and Michael Hutchinson. And some of you may know him from Santa Clara County. And then Melissa Millard Martin, who is one of our information system reviewers. And then many of you may know Maureen Baumann, who used to be the director in Placer. So that's our team at this point, and we're really looking forward to getting out to the counties. And our first review is San Mateo. In fact, we sent a draft agenda to them yesterday, so we're really excited about doing the San Mateo review in April, and then Riverside in May, and then Marin and Santa Clara in June. So those 4 are queued up, and we are working on the calendar for 18-19. So with that, I'm going to go through the PowerPoint, which is kind of an overview of the review system. And we kind of had to assume that for people on the DMC ODS side, that they had not necessarily ever been through a review. So some of this may be repetitive for those of you who are in integrated departments. But basically, we have these 438 requirements related to external quality review. And one of the unique things the feds did with our waiver, and I think it was because it was first in the nation, is ask for additional assessment of the evaluation of the waiver related to quality. And so we were contracted with to do these protocols. And they are, the core protocols are the same for performance measures, quality improvement projects, data integrity, and eventually we will do something with network adequacy. We're still working with the department on that for next year. And then client satisfaction, which is really, really important, and outcomes. So, you know, basically we want to make it easy for you to prepare and know what will happen. And we just finished the baseline data for every county for 4 years of all of your DMC services given to people with Medi-Cal. And then we're doing the first year of your new services, and that will be kind of your baseline, and we'll be able to see the trending. And even over the course of the last 4 years, just getting the ACA, the numbers jumped substantially in most of the communities. It's actually really exciting to see what a major role ACA has played on access, particularly around SUD treatment. So that's very exciting. And when we come out, we'll give you your baseline data as well as your 12 performance measures that we'll be crunching the data for and bringing out. And we'll post it for you early, so we'll have a good dialogue and you can look at it with us. And as I said, the review schedule, we should release a draft for next year at the CalQuick meeting. And we are kind of repeating this presentation in a slightly briefer form at CalQuick. And we'll be doing a PIP review of one of the PIPs. And we'll be continuing to do training related to the PIPs. That's been one of our most common requests, is folks giving us draft concepts, and then we work with you on what are your data sources and how to make good interventions and make the documentation as capturable and clear as possible. And so, honestly, one of the main things I've been doing is simplifying the PIPs, not making them more complicated, because folks tend to sometimes be very ambitious about looking at things in such a comprehensive way that it stretches our capacity around the data. So, next. So this is kind of an overview picture of the review process. And it starts with a 90-day notice. And so far, San Mateo's the only county who's gotten one. And at that point, we start working together on the review schedule. The reviews are from 1 to 5 days, depending on the size of the county. And then we have 30 days to write the report in a draft. We hand it off to DHCS for them to review and take their comments. Then we get the county's feedback, and we have a special feedback form where you can literally go through each section and correct any factual errors or unclear understandings, or if there's some additional data you feel like would reflect an issue that's being discussed. So then we integrate and look at those in final form, and then we submit it to the state and to the county, and it goes on our website. And my understanding is CMS does read these, and so it really is important to do a good job and really reflect what's going on in the county. And so the partnership with the state and the county is really important. So these are some of the key events that lead up. And one of the most important things, and you should be thinking about this now, is who is going to be your lead for the reviews. It's often someone in the quality improvement department or a lead manager. And for the sake of DMC ODS, it's really great to partner with your lead substance abuse manager, whether that's the designated AOD administrator or someone else. That person working with the quality improvement person is really critical. And one of the reasons we want to know early, besides working on the agenda, is also because we want to teach you how to upload into the cloud that we have. We have a HIPAA compliant cloud that is where we share documents. So we can share data with you, and you can share documents with us. And because of all the security things we're required to have, it's really important to do that early and help with any technical things that come up. And we don't want you to upload PHI. Just, we're really wanting to look at system issues, and so de-identified data is fine. And in fact, if you accidentally put some PHI, let us know right away and we'll get it off of there and work with you on it. But better not to have PHI on there. It triggers a whole bunch of things. So after the notification packet, the most important kind of, I'd say, heavy lift in terms of work is your quality improvement plan and goals and how you're going to evaluate it, which usually is picking 3 or 4 unique issues for the county, setting some measurable goal, and saying how you're going to evaluate it over time. And the same with cultural competence. It should be unique to your county. For example, Sacramento has 5 threshold languages. And when we've been out at Sacramento, we've done focus groups in Russian and in Hmong, and we've looked a lot at penetration rates related to those large populations of diverse people they have. And recently, they had a major influx of Syrian refugees, and they did a whole special program with some goals related to post-traumatic stress and things like that. So those plans really should be very much individualized to your clients, and particularly for those who might need substance abuse treatment. Then UCLA's treatment perception survey, we're hoping folks will do it at least annually, and I think we did it in October. So there should be some results soon from UCLA so that you could see the analysis of your data. And my understanding is they'll work with you if you want to drill down a little more and look at specific providers or look at particular issues. And then we want to basically review with you any questions we might have about your plan, and particularly how you're phasing your continuum of care over time. Because usually, I think with the structure of the plans, you could start with a certain menu and then you're supposed to build out each year. Okay. So these documents in this first bullet are the ones that are unique to substance use, and you complete them and upload them. And Tom will be going over them, but some of them may sound familiar, but they are unique to drug Medi-Cal. There's a timeliness self-assessment. There's an access call center, critical indicators, continuum of care form. There's an ISCA specifically for drug Medi-Cal, but we're also going to do a combined one next year for those of you with integrated data systems. Key initiatives and activity changes, PIPs, and then of course response to prior year recommendations once we're in the second, third, and fourth year. And then there's other documents which we've kind of mentioned, which are already things that are uploaded on the mental health side as well. Quality improvement, cultural competence, QI minutes, and anything else you do special that you think relates to quality. I was just in Sonoma with Maureen, and they had 6 different client satisfaction tools they were using. I'd never seen that many, and they had just finished a housing survey, which they were waiting for the results for, related to planning some of their system needs. But it was really a good effort around engaging families and engaging clients. And then we do have 2 conceptual PIPs that we'd love to see early. One's clinical, one's non-clinical, and you can have one that is for co-occurring disorders, either clinical or admin. But in that case, the others have to kind of complement it in terms of the focus. And they have to meet all the requirements for both sides, both the mental health side and the SUD side. Okay? So one thing that I always try to remind people, because it's not always obvious, that when we come on site, the best thing should be that by then your PIP has at least one intervention started to address whatever problem you're working on, because that makes it active. And you don't get any points in the way the federal protocol works unless it's active. So we want people to get their work acknowledged, and so we want them to be knowing about those time frames so they could have started one intervention at least by the time we come on site. We'll also be giving out $25 gift certificates to all the clients and all the family members who participate in any of our groups. And we will be trying to do some that are actually going to be in the community, and for larger counties in regions. So next, Kelly. Okay. So once we get there, what happens? And for those of you who have seen a typical agenda, we often will start with an overview with senior management of key initiatives, any response to recommendations, if there were any from a prior year, what's been going on in the county over the last year that are important, and what goals do you have for the coming year that you're working on. And this feeds right into that next bullet around the quality improvement and cultural competence plans and any PIPs. And so one of the things people often do is set a goal around, say, timeliness. A recent county I went to was working on timeliness for youth because they had dispersed contractors all over the county, and they were on all different data systems. So coordination of intakes was difficult. So one of their PIPs was to use a software program called Yellow Schedule, which I've never heard of, but anyway, and all of the legal entities could use it, including the access team, and they could get people queued up for their appointments much more quickly. And you could customize it. You could say, you know, these are the monolingual speaking staff, so, you know, you have to do matching and things like that. Anyway, having all of those things captured is really important in terms of the things you share with us. So one of the other things we do always is focus groups with clients and with family members. And we usually do ones with staff as well, line staff and supervisors. And particularly for the substance abuse program, we're always going to do a contractor focus group because they play such a big role in the DMC ODS delivery system. And we'll probably do site visits to all the access call centers and focus groups with their staff to make sure that part's working. So this is kind of a typical set of services that you'll see on the agenda. And we work very closely with you to form that agenda. We don't just spring it on you. And I want to acknowledge our two mock review counties who helped us refine our forms and even some of the scheduling issues, which was Riverside and Santa Clara. And so the forms that Tom will present, many of them were edited extensively after we got to actually live them out in a real county. And we got a lot of good feedback, It was really valuable. So we won't do any surprise sessions, and we will talk to you a lot about the goals, and you will have the forms early so that we can help you if you're not sure how to fill them out. So next, Kimberly. So what happens after? This is a 90-day process usually altogether, and it involves doing our first draft, and that means every session we get notes on, we get recommendations from each of the review team members, and we also get what they see as the county's strengths and areas where they may be able to improve and work on quality. And the lead reviewer, the IS reviewer, our client family member representatives will work together over that 30 days to put the draft report together. And then it will go to the state, and then to you, and then we'll be trying to finalize it. And so everybody gets a chance for input to make sure it's complete and up to date. And we really want to hone in on the issues of access, timeliness, quality, and outcomes. And one of the things we're hoping to work on in the clinical committee for you all is what are some outcome tools that are out there for SUD that help you be able to track client improvement. And the Joint Commission just put out a long list, and we understand that the National Quality Forum just put out some things. So we're going to consolidate that and make sure you have a list that you could consider related to outcome tools and feedback-informed treatment, which I know some of you are doing in your counties. So next. So now we're going to take a little, take questions on the PowerPoint, and we're going to start in on the toolkit. And just so you know, we didn't want to make this overwhelming, but we also wanted you to have all the tools so that you had them ahead of time, you could look them over, you could ask questions, and we could help, particularly for the really complex ones like the PIPs. And so why don't we take any questions that the group has on that overview of the process. Okay, could you come up here?
Very quick.
Thank you.
Thank you. Regarding the baseline data, I think it would be very helpful for the counties to have access to the data now before the schedule review, if that's possible.
I think we will be having a final set very soon, and we don't have a problem with sharing the data, because it is your data. We're basically just giving you back your data, and if there is anything that you don't think is correct, we would want to know that early. So I can work with Bill Ullum, our IT person, about when it's ready. We're starting with the counties that have launched, kind of making their data the top priority, and then we'll be working on the others. So I will inquire of the counties and see who wants it early to look at it.
Thank you.
Okay, and any other questions? Sorry to drag everybody up here, but
That's okay.
we feel like the county questions are really important, and we wanted to capture them, and given that we're not MGM, we have to do it in this kind of basic way. There we go.
Francisco with Fresno County. I just had 3 questions. One was related to the quality work plan.
Mhm.
We have one for mental health side, and we'll have one for substance use.
Mhm.
Can those be integrated, since we're only going to identify 3 to 4
Mhm.
items, or do you recommend that they be separated?
We've seen both. I think the thing to be cautious of, if you are allowed to do an integrated one, but it shouldn't look like substance abuse is shortchanged. And one plan I was given was about 80% mental health and 20% SUD. And we would want to see more balance there. So yes, you can do an integrated one, but the SUD focus shouldn't be shortchanged.
And
So,
that's what I was looking at.
yeah.
The next question I had was in regards to the survey for treatment.
Mhm.
The treatment survey, you said it's only going to be done at least once a year. Is there a specific time? I mean, I know you said at any time, but the consumer perception survey is done in November and May, and that's sent to the state and do an aggregate total.
Right.
Is the state also looking at doing aggregate totals or collecting them from counties, or does the county just maintain its own database and survey results?
If this is the UCLA treatment
Yeah.
perception survey, yeah, honestly, I think the requirement is once or twice a year.
It's October.
October. Sorry, Michelle.
So the IN went out, so this year I think it was November that we did it for the first round of counties, but then we set, like, I think it's the first week of October for the subsequent years of the waiver. So UCLA is basically compiling that information for the individual counties, and then they'll also look at it statewide as well.
Okay. So we'll receive notice from UCLA and we're sending.
Yeah, so the information notice, if you do want to look at it, is on our DMC ODS website, and UCLA, I would assume, would be sending out information. And there's a link to their website with, all of the instructions on how that can be submitted. But there's like pretty specific instructions on all of that.
Okay. And the last question I had was, you mentioned in regards to performance improvement projects.
Mm-hmm.
Was I correct when you said that there was a PIP on a shared database that was designed for multiple agencies?
Mm-hmm.
Okay.
Yeah, there was. And this was actually a mental health PIP, but it's a very relevant issue in terms of timeliness of getting people to assessments. And one of the things that is, I think one of the things Riverside's doing that's kind of exciting is their Access Call Center. They're doing a Cisco upgrade that lets them not only track all of these things that are needed related to timeliness and who gets assessments and where, but it also sorts in the dispositions of the calls and how many calls are dropped and how long are people waiting. And Ryan Quist knows more about that than I do, other than we're trying to document best practices related to access call centers because it's such a critical function. And Riverside certainly had major response to their access call center with 3,000 or 4,000 calls a month. So if anyone has had extensive experience, it's Riverside. And they've done it all with county staff, which is unusual to do it 24/7 with county staff. But there's other wonderful practices too, and we'll be happy to share what we learn with all the other counties, and including Fresno.
Okay.
Sounds
Thank you.
good. Any other questions? Okay, I think, Tom, you're on in terms of going through the toolkit.
Hello, everybody. It's nice to see you all here. Thanks so much for coming.
Presentation.
When Rama introduced those of us who are going to be on the reviews, you, I'm sure, noticed that we have a lot of depth of background in county experience. And so we know about the federal guidelines and the rules that we need to develop protocols to implement in the EQRL. And we are trying here today to make it clear to you what those are. And at the same time, we also know about the various array of unique circumstances in each county that make it easier or more difficult to do a variety of things. We also are aware of the plans that some of you have in your DMC ODS implementation for a more gradual phase-in. And so that will be something else that we'll be sensitive to when we come out. So we are human beings talking with you as human beings, and we are also representing regulations, and we hope that the experience is one that has a human touch, that it provides technical assistance to you so that you are not just learning about what your data shows and how close or far you are from meeting certain requirements, but you're also being able to make use of this entire process to improve care for the clients that you serve. And that's really ultimately what this is about. Those public entities, states, counties throughout the country that go into a managed, organized delivery system are more able to have a system of care where access, timeliness, quality, and outcomes can be achieved, and also have more requirements under federal guidelines to be able to demonstrate doing so. So I know from my background in working in a county that many counties under a review guess a lot. What are these people going to rate us on? What are they looking for? What does this mean? What does that mean? And we're trying to take away as much of that worrying as possible in this presentation and in the entire process. The toolkit provides you with a lot of background informational materials that you'll see. It provides you with the kinds of rating forms that you don't have to fill out, we do, but we wanted you to see them so you know the lenses that we're going to be looking through, so there's no mystery in it. And in fact, we hope that you'll use that knowledge to prepare documents to tell your story in ways that we need to hear it for the reporting that we will be doing. And then there are a lot of forms that you will be needing to fill out and uploading into a cloud-based system that we then are able to look at and review before we come out. So I'll be going through those with you today. As Rama said, there's 165 pages in this toolkit, so I won't be reading them to you. And this is a light overview to introduce you to the document. You'll need to take time with your staff then to really look through it more carefully and delegate out to different people on your team, different parts of it, and parts to complete and parts just to review. And you will have some questions. And please, don't stew with it. If there are things that are real puzzles to you, give us a call. And we will also be having an initial call with you when the process of your review starts. And that will be a forum for further questions you can ask of us. So there'll be a lot of back and forth that's possible. So you needn't be guessing about things. And with that said, are we ready?
We're on page 3, yes, about
Okay.
this toolkit.
The first few pages of the toolkit that are entitled About This Toolkit and EQRL Background and Activities just really are introductory, and they are things that Rama did so well in portraying in her presentation. The value of having that here is you can always go back and reference it. And of course, those of you who are listening in, and this may be many months after this actual presentation was given, we hope that this video will be useful to you as you get introduced to the document and go through it. On page 4, the background and activities are shown, and what this has, for those of you who are interested, it cites all of the different federal and state regulations that form the underpinning for the EQRO review. We do a lot of work in creating the forms, in effect, in figuring out how best to implement the requirements in a review. But the basic requirements themselves are already designed and articulated by the state and federal governments. Moving on, I particularly would like you to note pages 8 and 9. These are the key components that are the standards which guide a lot of the review. And the pages after that are the actual forms, rating forms themselves that we as reviewers use in rating what we are learning from your documentation and the sessions that we're in with you. So that's a key lens that we look through. You don't have to fill any of this out, but it's a useful thing for you to know about so that you can help address the kinds of informational ratings that we're going to have to do in how you tell your story. So we need your help in organizing your information well. Tell us what you did during the last year, particularly with regards to these lenses. Now, these forms are what we also use in the mental health reviews, but we have redesigned them for the drug Medi-Cal review, and I particularly want to point your attention to, if you look at 2B, tracks and trends access data from initial contact to first MAT and NTP appointment. There is also a tracking for other kinds of sessions, but this is particular, obviously, to DMC. If you look at 2D, we've got a reference here to access to follow-up appointments after residential treatment. In the mental health plan, it would say inpatient. And related to that, the next one is with regards to withdrawal management. And we'll want to know how you're tracking what happens to people after they're leaving detox. On the next page, 3C, you'll note that effective communication from DMC ODS administration and SUD stakeholders for their input. So this isn't now the mental health plan or the general behavioral health department. We're really looking to some specific authority and communication from the department with regards to DMC ODS. If you look at 3D, evidence of ASAM continuum of care. So we're pretty special on the DMC ODS side in actually having a clinical system of care blueprint through the standard terms and conditions using ASAM criteria. And we'll want to know how you're implementing that. 3E is medication-assisted treatment services. The entire nation is getting increasingly interested in MAT for the opioid crisis and other reasons. And so we want to really focus in on that in the waiver and through the EQRO. 3E is ASAM training and fidelity to core principles. The core principles, keep in mind, are not, they go way beyond criteria, and they have to do with, is care really client-centered? And what that means, how we will be rating that, you can look up in 3E and see a lot of the details of that. If you look at 3H, client perception of care surveys, so we're using a different instrument than in mental health, as was spoken about 15 minutes ago. Okay. If we move on, there are many pages that look in detail for us as raters, and we'll just skip through that, but you can look at kind of the deeper meanings of those different key components. And we'll move to page 34. And 34 is about the EQRL processes. And this is a page that I won't go through because Rama already did, but it's something that I think you will reference time and time again about the various steps in order of what happens during the review process. Page 35 is where it all formally starts. We will send to you a notification letter. In the spirit of, as Rama said, no surprises, we want to give you plenty of time to prepare. So we will be notifying you actually an extra month before what we usually do in the mental health plan. So 90 days prior to the review, you'll get the letter. And the letter has a lot in it that I'm going to go through. On the first few pages, it will let you know who's coming from our side, and it will give you some idea of what we'll be looking for and what sessions we'll want to have and what the dates are and who the lead reviewer is, who will be your key contact. On page 38, you'll see a list here of the documents that you'll be needing to complete and which ones we'll need you to upload into our system. On page 40, you'll see parameters for a few focus groups. We usually have at least one consumer client focus group and one family member focus group. In some counties, we might have more than that, especially some of the larger counties. This gives you some idea of what kind of organizing functions you're going to have to perform, as in making sure that you get the right people there in the room to be the focus group participants, and how we structure the group so that you can convey that to the clients and family members who are invited. We also have some other focus groups with clinical line staff and contractors, and we'll be sharing that information with you as well. On page 42 begins instructions on how to upload materials into Box, which is the vendor, the website that we've selected as the one to help us technologically with the file sharing capabilities that we have. We get dozens and hundreds of documents from every county that we work with, so we need a huge system for file sharing. I would say here that the more documents the merrier is not true. And we don't appreciate and can't read hundreds and hundreds of documents before a review. And we would like you to observe the guidelines we have for what minimally we do need, and you needn't go much beyond that. In addition to the guidelines here for how to upload, we will have a point person who will be assigned to working with your point person on the technical aspects of how to upload the documents so that there's no mystery to it. On page 45, you'll see it is the preliminary agenda call, and what this is about 2 weeks after the notification letter, we will have scheduled with you a preliminary call. And it can involve whoever you invite from your team who will be most active in preparation. We'll go through the list of the required sessions and the ones that are optional, and we will have proposed to you some idea of an agenda, but that call is one where we really talk about how to tweak it and what you might think would be most useful, and we'll develop the agenda somewhat together. On page 48, we have an attendance log. So this is something that we'll ask you to print out and make sure that everybody signs who participates in any one of many sessions during the review. And then I think we actually take it with us when we leave. And we need to keep that as a record. I was astonished at first at how much documentation at how many levels there are that we have to hold and keep. We have supporting documentation in our records about who attended the sessions. We have our notes. We built upon our notes and your documents a whole set of information that we use for our ratings. The ratings by several reviewers who go out are then all compiled by our lead reviewer who develops the report. So while the report itself that goes to you and the state is much more concise and complete. There are a whole chain of supporting documents that undergird these, and it starts with the attendance log. On page 49 is a list of all of the potential EQRO review sessions as a kind of menu from which to pick. And these documents that we're going through now are all part of what's considered during the call and in the notification letters. We'll now look at page 50, which is the performance measures. So this is a big deal. And needless to say, as you would look at them, they're quite different than the mental health plan's performance measures. DHCS asked us to develop 12 measures for year 1 and 4 more for year 2 for a total of 16. Most, not all, but most of the measures are pretty classic measures in the sense of a numerator and denominator, creating a statistic with some expectations of what that statistic should look like. The percent of clients who da-da-da-da-da. They are, as much as possible, measures that have been established at a national level as well-founded, meaningful, and where counties are capable of collecting the data that goes into those measures. We developed a clinical committee of many people from counties across California who we worked with. Rama did an amazing job of first surveying nationally what measures were available and worthy of consideration. And then we had a really enthusiastic group with some very compelling discussions that went on for months, evaluating the different measures as to their feasibility, their meaningfulness, their scientific validity, and coming to the measures that you see here and you'll be able to look at in your toolkit. We'll be adding 4 more. And these are measures for which the data will be accessible to EQRO, and we will be looking at that data, crunching the numbers, developing the results, and providing that to you when we begin the review. So these are not measures where, for the most part, you need to do the work. That's what we will be doing. And we'll be giving you the feedback then on how it's going in your county according to the data. Always something very interesting and useful. Moving to page 59. These are questions for focus group participants. And I'm going to be going through 5 of the forms. These are not forms that you need to do anything with. These are, again, part of the lens through which we look at things. So you will know for the different focus groups. We will have a facilitator at each group who will be helping with these questions. So the first 3 forms are forms that we ask the participants to fill out in writing. So we have a form for TAY clients, for adult clients, and one for family members. And we make it really friendly and easy, as you can see, for people to fill it out. And we will score these and use these as part of the data that we gleaned from the review. We're very careful to not have any identifying information in what we report on. We also make it such that for the client and family member focus groups, there aren't staff who are there from the county, so people feel free to talk about whatever their experience was more freely. The facilitators also have some structured questions that they verbally ask in the review, but we wanted to show you here the ones that are the actual written forms that the clients fill out themselves. Moving to page 65, This is a brand new form. It's fairly extensive. There's nothing for you to do about it. This is a set of questions, not all of which a facilitator has to ask, but it is a helpful guide for them of points to think about and focus on in the group of people with whom they are interviewing. And this particular one, which we think is especially important for the drug Medi-Cal ODS, has to do with criminal justice. So this would be a session, and it wouldn't be in every county. It might not be in some of the smaller counties, but where there would be people from the various criminal justice agencies involved in working with behavioral health, and particularly with the DMC ODS. So how is the rollout going according to judges who have to make decisions about referrals to treatment? And how about with probation and with sheriffs, and particularly sheriffs who oversee the jail, etc. So this would really seem to have a lot of relevance. Moving to the next one, which is on page 68. This is an example of questions that a facilitator would use in a group on cultural competence and disparities, and how the county's initiatives are rolling out with regards to those issues. Again, nothing for you to do. This is a lens through which we'll be looking and asking questions about. The next page is 71. It's the exit session. So at the very end of the review, we have an exit session. We make a few comments. They're very high level. We have a lot of information that we have to sift through before really coming up with anything definitive. It's more of a chance for you as the county to say some things that you think need correcting as impressions, or have questions that you want to ask of us. And it's our chance to reflect on some things that came up during the reviews, and perhaps some additional documentation that we decided we think we need from you in the next few days. So moving to page 73. These are the documents that we need you to complete and return to us no later than 30 days before we come out to the review. So you have 60 days to do this in. First is a standard, what we look at first with the mental health plans, that we won't be needing from you the first year of the review, because it's the response to the prior year's recommendations that we made and what you did during the last year. But we wanted you to see it anyway, because it's relevant for year 2. On page 75, for the mental health plans, there's always something to say about significant changes and initiatives during the last year. These can include environmental changes, such as recently we did some reviews with counties that had experienced the fire. It certainly affected everyone. But there's always some new initiatives. For you guys, everything's significant and new. There's lots and lots to say. So this should be a very a full document. And by full, I don't mean many pages, but just to highlight the different things. And then when we have our session, always at the very first session, at the very beginning, it's a presentation by the county, and it's a kind of a show and tell of what you've done, what's changed. And that'll be a chance to also talk a bit more in depth about it. But this gives us a heads up. Next is on page 76. So I think these now are in no special order. But this one is a brand new document. This is not something used on the mental health side. So for most counties, there is a brand new access call center. It may be brand new in the sense of new staff and new training and new focus within their existing access call center for mental health that now is doing both, or it may be a separate call center entirely. But whichever it is, it's certainly going to have new staff, new protocols, new ways of doing things. And there is a art and science to call centers. Some of it has nothing to do with behavioral health, in fact, but it has to do with monitoring call abandonment rate, call talk time, call wait time, call volume, things like that that are very standard in the field to have that kind of data feedback on a daily basis so that managers can be alerted quickly when there are log jams and whatnot, rather than having it blow up over time. So we developed in concert with some counties, and I think Riverside really stood out in helping us with this, but our clinical committee was helpful in developing a form that asks a lot of questions about the things that are important to know and attend to in developing and managing your call centers. Now, this document is somewhat aspirational in that you may not have it all. You may not have thought through it all. So we hope this document will be helpful in getting you to think about it and to perhaps attending to some things that you might not have attended to right at first when getting this out. We recognize that for many, the initial implementation is a scramble, and there's a lot of, to put it quaintly, lessons learned and things to improve. So this is not looking at your county as an expected finished product that you've been working on for years, but a work in progress. And we hope that this form will be helpful to you, and it helps us create a baseline of performance for you as a county so we know what to recommend and look for next year. But also, it's very important that we do this for the state, and frankly, it'll be for the whole country, to tell the story of what's happened in the rollout so that other states that decide on this waiver will know what to expect, what kind of timeline is reasonable for getting this and that going, what some of the major hurdles tend to be, and can learn from our mistakes. Okay. Next is the self-assessment of timely access, and this is a standard form. It's very important in the managed care federal guidelines. There is much of this that is quite similar to mental health plans. Some of the things that I think you're probably all well aware of that are fairly new in focus, although not in regulation, mental health as well, have to do with time from first contact, first request till actual appointment. And for those of you who are monitoring this, time of first offered appointment. And those are big lifts. Frankly, not just substance use, but the mental health side as well. And they are a required part of attention. And it's expected that these are sometimes going to be the subject of PIPs because there's a lot of learning and getting an infrastructure built for this. Continuum of care. So this is a form that is unique to DMC ODS and it's built on ASAM, and I feel proud of us that we are doing this. Not all entities in mental health and physical health have that kind of organized system of care and clinically based approach, and I think it's commendable that we're starting off with that as a centerpiece in the standard terms and conditions. And so this is asking you, what have you got going? Tell us. And we know that there's a phase-in, so we want to know at the snapshot in time of the review, where are you then? And then we'll be following up each year to find out how you're expanding further and fleshing out your continuum of care. On page 93, we have what internal to EQRL we call the ISCA, the Information Systems Capability Assessment. This is a pretty extensive document. I think it's 20 some pages, 27 pages. This document covers a lot of ground. You'll want first and foremost to involve your IS staff in leading the way with filling this out, getting the information that's needed. Your data analytics staff will be participating in this, and it varies by county as to who else gets into this. Certainly some of your billing folks to get into the claims data and how you handle that. Some of the things that are covered in this assessment. The form that you have in your toolkit is just for DMC ODS. It's not for mental health. Because there is so much overlap in many counties between the IS system and staff for mental health and substance use, we have created as an option for fiscal year 18-19, so starting in July, an integrated form. So then for those counties that want, you can just fill out one form, and it will have some questions where it's obvious that it holds true for both mental health and substance use. And for questions where it's not at all obvious or we know it's different, we'll just have different columns for the answer to ask what you're doing for mental health and which for substance use. We are required at the end of a year to roll up the results of our review findings for mental health into a statewide summary for DHCS. And we present that publicly for those of you who are interested. We are required to do the same thing for drug Medi-Cal ODS, a separate statewide report. So we have to have information from both. So when we talk about integration, quote unquote, of reports, it really means, as Rama said, a side-by-side review and side-by-side data entry by you into forms, not a single set of responses that we then would have to pull apart and try to guess which is mental health and which is substance use. But we're trying to make it as easy as possible for you. So in the case of ISCA, where there is so much overlap, we're also going to be giving the options of a single form where we'll have an opportunity to answer separately where separate answers are called for. So topics in the ISCA include, it opens with a section on general information. It then moves into what are the primary kinds of IS products that you have and use. And if you think about it, they can range from an electronic health record to some separate kinds of software that are used adjunctively to that for billing. For scheduling, Rama mentioned one in a review that came up. There may be a different software for EHR for mental health and then for substance use. Some counties have it separated. There might be a separate software for monitoring the phone calls in the call center, and so on and so forth. So we ask you to list your major software products that you're using. And then with each one to let us know about what stage of deployment it's in. And we all know that especially for a comprehensive EHR, it's usually phased in, or it could be over a period of years where the phase-in happens. So at the time of the review, what's done, what's yet to be done. Again, we are looking through our review at counties as a moving, developing journey, not as a finished entity and product. So we want to know, where are you in your journey and how can we help? The ISCA also asks questions about the standards that you have set for various aspects of data entry and processing and how you train your staff in that. Who's responsible for those functions? How many users you have for the different kinds of software you're using? How you use your information systems in communicating with providers and connect with them, especially your contract providers. and how you use information systems in claims processing. What are your securities and controls? How is data accessed? And how is it analyzed? And how is it used? So it's a very, very important centerpiece document. And part of the federal requirements, as you might guess, with all this interest in data, is what assurance do we have of the integrity of the data? Which then goes to how strong are your systems, your IS systems. So it's all connected. So 117 will show you the form that you have to fill out describing your 2 performance improvement projects. One of them is a non-clinical PIP, as we call it. The other is clinical. And the basic difference between the two is one involves clinical interventions and the other does not. There might be follow-up calls to people who are not showing up, or reminder calls to people so that no-show rates drop. And the clinical PIPs are any one of a number of kinds of interventions to improve care, improve client outcomes. What isn't as different, and this is a point of confusion I'm learning a lot in counties, is whether it's a clinical or a non-clinical PIP, it should always involve, and this is the marker of a PIP, should always involve what difference did it end up making in the lives of clients that you served? What kind of outcomes? So a purely process study such as did you increase your bed census in a certain residential treatment center, or did you increase your rate of follow-up calls to clients? That by itself isn't enough for a PIP. You've got to take that extra step of what difference did it make in the lives of clients. There's a lot of methodological guidance in the documents. A lot of questions we get about that. But really what's most important that we want to encourage when you start is what are some areas where we think with some interventions we could really improve the lives of clients? And where if we really took a magnifying glass to certain processes that we think will help, we might make a difference. Start there. Make sure it's meaningful to you. The spirit of quality improvement really doesn't come from the compliance world. And it's a passionate organizational culture kind of motivation to be excellent in providing, in our case, great care to clients. The manufacturing industry, it's great pride in their product. It's intended to motivate staff and all the people in the organization to want to do good for the sake of clients and for taking great pride in our work and in the importance of easing suffering for our clients. So if you start in that place, and you're well grounded with your PIPs, and then we can help with the methodology and making sure that the design is good. And we would really love it if you checked in with us before you got too far along, because it's just so disheartening to wait and then work hard at something for a year and then find when the review comes that it was off track. You have to take another year to recalibrate. So please, we're here for you, and we'd love to hear from you. We enjoy talking about this stuff, and we'll be glad to help. Okay, page 126 is the PIP validation tool. You don't have to look at this, but this is what we fill out. This is the lens that we look through when we're evaluating a PIP. And we thought to just be transparent with you about this and the lenses that we look through, so you know what we're looking for. And then you can use that knowledge to make sure when you're designing your PIP that it's going to speak to the things that we're looking for. I want to say one thing. There are some things in the validation tool that have to do with certain kinds of designs, experimental designs, that involve a matching control group. And then what plays into it is statistical significance. Very few counties do that. And it's okay. You don't have to do that. On page 134 is just a page on quality management. And with quality management, there's no form for this, but we do need to receive from you as a document your QI plan. And we want in your QI plan to see not just nice strategic directions, but we want to see goals for the year, and we want to see measurable objectives for the year that can form the basis of an evaluation. And we want to see an evaluation so that you know and we know how'd you do. So we need, for starters, 2 documents, a QI plan and an evaluation. The QI plan, as we discussed earlier, can be a separate plan for DMC ODS, or it can be integrated in your document that includes mental health. But when it's integrated, it needs to look like it's a lot more than an afterthought. In addition to the QI plan and the evaluation, we want to know how regularly you're working on it. So it's not just a document. How regularly you're tracking progress. And based on the tracking of progress, how regularly you're reshaping it. You're adding to it. You're changing some of the plans that aren't working so well, whatever. So, in addition to those first 2 documents, the plan and the evaluation, the other thing that we want to see are your QIC meeting minutes as your evidence of regularly looking at the plan and tracking progress. So your QIC meeting minutes should reflect an agenda that attends to your QI plan. Just, if you think of it, it's just like your client initial assessment, golden thread flowing into the treatment plan and then flowing into the progress notes. Same idea. And if your way of tracking it isn't the QIC, it's some other mechanism, some other committee, that's fine. Whatever that committee is, to show us, tell your story to us. Show us how you, through documents that you submit to us, that you're really paying attention and monitoring what you said you were going to do. Same thing with a cultural competence plan. Same kind of thing. On page 134, we provided for you a fairly extensive document. It's Santa Clara's quality management plan. Thank you, Santa Clara. We thought this was a good one. You needn't copy it in structure, and you might have a different structure, but it has a lot of good ideas in it. And so for those of you who have never written a quality improvement plan, especially for drug Medi-Cal, this can help with that, give you some ideas. Lastly, on page 165, there's just a short list of mostly the documents that I mentioned, but the one at the bottom that I just wanted to mention that we also need from you, and we will all the reviewers will read it before coming out, is your DMC ODS implementation plan. That really tells your story before you started about what your phase-ins were going to be and your network adequacy and et cetera, a full array of plans for implementing your DMC ODS. And that is the toolkit. So we've given you today a high-level overview that Rama gave with the rationale, and then I've just walked you through a very basic introduction to the forms, and it's now your time to go read, and for some of you, you've got a review coming up shortly in April. For others, it's going to be a year off, and we hope that these tool documents are useful to you. We've put a lot of time into them and are really kind of happy today. We're a bright celebratory tie and all for having this kickoff for us of having all these forms finally to share. And so with that, we'll have time now for questions.
Yeah.
Hi, I'm Michelle from San Francisco. I just had a question about the consumer focus groups. I think you call them client family focus groups. There were 3. There was a youth one, a TAE one, and an adult one. And I know with the provider group interviews, there was a menu of options. And I just wanted to clarify if the expectation is for counties to have 3 focus groups based on the age groups versus, I don't know, other things, or if it was going to be 2 versus 3, depending on the size of the county, or just to clarify.
So for most counties, there's a minimum of 2. Obviously in LA, we do a lot more, but it wouldn't necessarily be TAE, parents, and adults. We might do 2 adult groups, one in one region and one in another, to see if the feedback is similar. We might do one at a residential program and another one at an outpatient center. And so we look a lot at what your threshold languages are, what your regions are. A lot of times there's a structure of how the county is organized, and they may have one central center and several kind of satellites. And we try to make sure we're not neglecting some of those satellite sites. And so it's very common, for example, to one year we were, for example, in LA, we were in the Tarzana area. That was the region. We spent 2 days doing all kinds of different focus groups, staff, clients, contractors, a youth program. And then the next year it might be in the Long Beach area. So that it try to rotate around so you get as complete a picture as possible of client feedback across the county. And then of course with penetration rates related to different ethnic groups or spoken languages, we'll also try to focus in on that. But we usually have, in a county the size of San Francisco, 2, maybe 3 the most. LA often has 5 or 6. But it is all kind of geared by county. And for example, I was in Riverside last year. I think I helped on the mental health review. I spent 2 days in Indio, doing different groups in that region. And so that's not atypical, is to rotate across the regions and get a sense of unique client needs in different outlying areas. And I honestly think that'll be even more important with the network adequacy issues, because it's the folks who are in outlying areas that are sometimes the most challenging to make sure we get access to.
That was my other question. So following July 2018, for those of us that have reviews after that, do you know when you expect the network adequacy form to come out? So we sort of have an idea of what to prepare for?
Actually, we will be working with the state on that. We don't know yet either.
Okay.
We've read the bill, we're pondering it, as probably many of you are, and trying to think about what data, what software, how do we do that. And I know the state is actively working on that right now.
So yeah, I just wanted to say that we are working also in conjunction with our mental health division, because we know that there are similarities to those requirements, and we've been working with CBHDA. I know that the data collection tool that DHCS put together went out to counties, and feedback was due, I think, yesterday actually. And so we actually have a meeting this afternoon to kind of go through all of that feedback. And we're also working on an information notice that kind of outlines the network adequacy requirements the department would expect. And of course, we incorporated feedback from the counties already on that, and then the additional feedback that we hopefully got yesterday with regard to the information notice that outlines all of that. And so then I'm sure it'll go back out, or at least, I'm not sure the specific timeline for it, but we are anxious to get it out. We know that counties are anxious for that information, and Ram and I had talked as well about, you know, what this means for EQRL, but there's still a lot of internal stuff that we have to work through, so I can't give you specific timeframes, but as far as getting out, we know that it needs to come out quickly, so we're working on that right now.
And just so you know, internal to our organization in terms of our data analytics staff is we do have GIS capacity and analytic capacity there, but need to understand the rules and the structure before we run off and make something up. So we're waiting for some feedback from the state, and they're obviously engaging you around that very important issue. And it's complicated. It's not an easy thing, and especially in some of the huge rural areas with very limited population.
Yes.
Thank you. This is probably a bit selfish of me. I think it's for clarity. But I think at least myself struggle of the definition of initial request. I think coming from the mental health side, you know, sometimes we have parents with youth and the request for service, however, they come from family that involve court. So there's a timing that's involved. So I think having a clarity of initial request would be very helpful. I don't know if that would need to come from state. That ties back to the performance. I think it's performance number 2, talks about initial request. I think in that grid, I think it would be helpful if county knows that this is something that counties have to produce, or would it come from EQRL? I know that, you know, when perhaps for the mental health side, 30 days before, EQRL gives counties approved claim reports, and there's some information that, you know, counties have to provide. I think include in that grid, I think would be helpful that this is something that we expect counties to produce on that grid. I think 12 of them, I think.
Let's see. So regarding your first question, that's very interesting. And there are a lot of nuances, aren't there? And I think that the best resolution to that would be some of the people more in the weeds with this in counties through CBHDA working up some recommendations with the state, THCS, as to what the guidelines should be. I suspect now that counties are on their own to interpret, and so there's all kinds of things, and there's a lot of learning curve work that I think we all need to do, and I think EQRL can work as consultants in that, but for really more formal definitions, I think that would be helpful, and I think it would be a good thing for CBHDA to revive its old CADPAC Data Outcomes Committee. And I know there's been some discussion about that with people at DHCS, and I think it's something that could have a new life once some things with CalOMS as well were made more clear after certain IT infrastructure stuff is worked out. So I think this year, especially next few months, is probably a good turning point to start looking at that, and that's probably only one of several issues. So thank you. I think that's a really good point, and I see Tom Renfrey in the background here, and so listening in, so he's heard, and there's Michelle. So we can, and some of us are meeting with the state and UCLA next week, and we can bring this up. So as far as your other question, so there are some things that we, most especially claims database, where EQRO has access, and we work on those things, and we give feedback through the mental health reviews that we've been doing, and now with DMC ODS, we will be giving the results to the counties. The thing about the timeliness self-assessment form and the data about time from first request, that's not really claims data.
Right.
And so it's something where we look to the counties to develop and track that, and we ask a lot of questions then. How did you do this? And we, I guess, expect a certain amount of just veracity from the counties that we trust. But it's not like we've got a database then where we know when the time of first request was, and we're checking that against what a county said. So I think we just need to all agree on the importance of this and work together on some good standards for it.
I would just think in terms of clarity, that on the grid itself, that we indicate that, counties state where EQRO does not have access to this information, so you have to produce so that it's clear.
Oh.
I mean, the guideline is very good. It's just that, I know that the guideline is out there, but we know that claims data comes from EQRO.
Yes.
And, because it's listed on the same document, I think it would be good for, we know, counties know, but just for clarity that this is something that counties must produce.
Probably the most typical tracking is linking the Access Call Center system, whether it's a log or it's a software or it's a database, to the claims system, so you can see when their assessment happens and then hopefully their linkage to treatment. And it varies throughout the state how much linkage there is between that, and it's very common to go into the Access Call Center and see multiple screens, and they have their electronic health record on one so they can see if it's an existing client, and then they can see who their therapist might have been or their doctor, and trying to link them back to treatment if they've fallen out. And one of the things that really helps counties a lot with timely access and tracking that is if they have some core walk-in services where they can present and wait and see a clinician, because then you're really seeing them the same day, and then you're linking them to treatment. And that having walk-in services versus people having to plan and show up, which our clients are not very good at in some cases, really helps bring that timeliness down. And we've seen that consistently over the counties, that immediacy of the access is really helpful. And so one thing I was impressed with in Riverside is they were doing the full ASAM screenings on the phone and linking them right then to providers. Now, not everyone has that capacity. Some folks are doing a kind of a triage and then linking to the full assessment. But the more rapid you move into the treatment process, obviously the better the timeliness is. So.
If I could add to that, because I have a question about how EQRO can help. Especially for medium to large counties, the setups have been such that not everybody goes through a call center. And there are various clinical reasons for that to avoid logjams and make it easier, especially when it's outpatient treatment that's regarded in big counties where there's outpatient treatment centers all over. So it raises a kind of responsibility for outpatient treatment particularly that wasn't there before, which is to log the time of the first call for an appointment. That wasn't a responsibility before. And for a system to take responsibility for tracking all of this, it then becomes incumbent upon those outpatient providers to have to do that, or else the system has no alternative if it's going to track this, but to have everything go through a call center, which most people don't think is really desirable. So hopefully the administrators in each county present that dilemma to their network and get them involved in deciding that yes, we want, on behalf of good access, to take that responsibility. And so then the county has the challenge of getting that data uploaded from the providers to the county in some central database so that they have all that data so that then they can report it, not just to EQRO, it's got to be reported to the state as well in the system audit. So this is a huge lift. And in CBHDA, we've been pretty explicit in talking about it. It's a revolutionary change. So can we be helpful in a way in EQRO in pointing that out and putting that in a form? Is that something that you would, is that part of your suggestion? Okay. Yeah, I think that's a really key thing. We'll look into that.
I just had a question about the ISCA. You guys had made a comment that next year it may be integrated with mental health, and I wasn't sure if that was next fiscal year or next calendar year.
And let me say something else about that. That integrated form is not just for counties that want to do a side-by-side review. Counties that want to keep their reviews separate could also use that form if they found it easier. And then they have it done, even though the reviews might be timed differently. But they've got it done for both. And one of the reasons why it's not now, it's next year, is because it took a lot of time for us to figure out how to design a form that could still be translated into fields that could be pulled apart with the DMC and the MHP responses separated for the report roll-up that we need to do at the end of the year and make it all work. And we've done all of that. But then the other thing is, then we wanted to vet it through CBHDA's IT committee to make sure that it looked okay to them. And we also have thought that we should, for mental health as well, be separating out and adding a bit more to a whole section on contractors and how IT for contractors figures into the whole system. Because we are entering into a new era where there is much more electronic back and forth exchange of information and questions about, does everybody need the same EHR or a different one, and how are you doing interoperability and stuff like that. So all of that's going on, and it's a very cutting edge thing, and we'll have it ready for July.
So as you plow through the 166 pages, we're available to you. At the end of your thing, there's our contact information, as well as Michelle, Ilana, and Wahida, so that if you have something you feel the state needs to clarify, you can contact them as well. We're doing a major upgrade to our website this coming weekend, and it should get very pretty, but also very organized. It's not so organized. And we do have a good link with DHCS's website on the DMC ODS link, but we want to really make it a lot more robust and clear cut. And don't feel like if you can't find what you need, you can't just call us or email. We're very good emailers in our group, and very county aware of some of the systems that you're dealing with. And so, including some of our IT staff have expertise in Cerner, Anastasi, as well as Avatar. And hopefully we can make your lives better by being able to make sound recommendations related to those IT systems, which we know can be really challenging and really either an aid or a barrier related to doing some of this work. Okay, thank you. Thank you very much.